Hi, I'm Dr. Tariq. I'm one of the transitional year residents at Kendall Regional Medical Center, and I'll be presenting to you a topic today, inflammatory bowel disease with compounding gastroparesis. GI manifestations of inflammatory bowel disease can often mimic those of gastroparesis. Patients with inflammatory bowel disease, if they are worsening or developing new symptoms, they should be evaluated for a possible compounding gastroparesis. Nutritional support for patients with multiple GI complications needs to be carefully considered. I present to you a case in which a patient with pre-existing ulcerative colitis and Crohn's disease ends up developing gastroparesis. Our patient is a 22-year-old female who presented to Kendall on the advice of her gastroenterologist following diagnosis of gastroparesis of unknown etiology approximately a year ago. Her GI recommended that she undergo an endoscopy and an elective PEC tube placement since the patient had been experiencing intractable abdominal pain and nausea for the past year. She was not able to tolerate feeds orally. She was currently receiving total parenteral nutrition via central line. She was diagnosed with ulcerative colitis in 2008. While being medically managed with ulcerative colitis, the patient began experiencing arthralgias and abdominal pain in 2017, and then she was diagnosed with concomitant Crohn's disease. She has no family history of inflammatory bowel disease or autoimmune conditions. Additionally, past medical history includes epilepsy, chronic kidney disease, asthma, depression, and anxiety. On arrival, she reported abdominal pain, nausea, vomiting, recent weight loss, fatigue, and generalized weakness. Her vitals were stable. She overall appeared anxious and distressed and dehydrated. Abdominal exam showed a soft, non-distended abdomen with generalized tenderness on palpation and normoactive bowel sounds. Rest of the examination was not significant. Overall, she was admitted to the medical floor. Her home medications were reconciled, and she was placed on GI prophylactic medications. Here is a list of medications which she was receiving while she was admitted. We started her on IV fluids, ketorolac for pain management. An uncomplicated PEC tube placement was performed later that day, and there were no abnormalities visualized on the endoscopy. We consulted nutrition for the PEC tube feedings, and as they were initiated, she was monitored and she was able to tolerate the feeds. She was discharged home after 7 days. The main purpose of presenting this topic is to reflect on the fact that gastroparesis is a debilitating illness, and symptoms such as nausea and vomiting, they can impact the quality of life, can lead to malnutrition. And also in patients with underlying inflammatory bowel disease and gastroparesis, they end up getting some form of intervention for nutrition. And in some cases, such as in our patient, the placement of the PEC tube becomes the only therapeutic option. Again, our patient, who is a young 22-year-old, she has a history of multiple illnesses. On top of that, she develops gastroparesis. Now she has a PEC tube. So we need to treat her with a multidisciplinary approach where we optimize her nutrition, give her emotional support, and treat the underlying medical illness. And ultimately, it can lead to a positive outcome and contribute to her growth and well-being. Thank you so much.